So since we now come to the end of this presentation, I would like to welcome the other speakers to join us for this Q&A session. So Christine, you are there. Good. And now, Dr. Reina, are you here?
Yes, I hear. I listen.
Maybe Dr. Reina has other business to take care of. Never mind. Okay, Christine, do you have any questions that our audience would like to know?
Yes, so the first question is for Dr. Figo. So the question is from Dr. Carlos Correa. So he would like to know whether we can always see the posterior femoral cutaneous nerve in dissections, and also whether this nerve is inside the paraneural sheath as well.
Okay, that's a question for you, George, because I know you have done some good work in this area.
First of all, no, they are not in the same sheet. They are separated from each other. There is a dense connective tissue layer in between the sciatic nerve, and superficial to it, you have the posterior femoral cutaneous in the fat-filled fascial tunnel. Anyway, concerning dissections, and also there are already enough manuscripts concerning the visibility in ultrasound. The posterior femoral cutaneous nerve is easily detectable and traceable by ultrasound on the thigh region. What is important for you is that you have the posterior femoral cutaneous regularly reaching the proximal third of the leg, and this is not that true because you get a prolongation of the nerve until also the distal leg areas in, let's say a third of our cases. What we found was about 30% and 40%.
Thank you, Professor Figo. So we have another question for Dr. Kamaka. So 2 questions for Professor Kamaka. So the first question is from Dr. John Tay. So he would like to know, would you try to achieve a circumferential spread with needle adjustment while you're performing the sciatic nerve block? And another question is regarding routinely adding steroid to prolong the block duration, and also use it as a preemptive to prevent preemptive medication to prevent inflammation.
First question, do I deliberately chase the sciatic nerve for a circumferential spread? I think the answer is no. Over my research work, I have now homed in on performing 2 injections subparaneural below the divergence. So as you will see that these are smaller nerves, and I find that it produces quite good spread. Yes, it is not circumferential around the tibial and the common peroneal nerve. But my worry, if you chase and try and create a circumferential spread around the tibial and common peroneal below the divergence, you hazard injury to the nerve. And more importantly, some of the smaller branches like the sural communicating or the peroneal communicating branches, these are very small branches. You may risk producing damage to this. So I don't chase it, but I am more inclined, or if you ask me what kind of a popliteal sciatic nerve block I would want you to do in me, I would say do 2 separate injections into the common peroneus and the tibial nerve below the divergence after hydrodissecting it with some normal saline. Next question is, do I add dexamethasone to my injectate to try and prolong the duration? As I have been saying all this evening or this morning for you or afternoon, that it really produces such long duration that any prolongation is not desirable. I rather want a block that is much shorter, where recovery of the sensory motor function certainly recovers earlier. Now, in terms of reducing any anti-inflammatory effect, I think the jury is out there whether it really works like so. So I don't have any comments on that.
Okay. Thank you, Professor Kamaka. So I think there is another question for any of the panelists. So Dr. Malfedi Antonio Cole would like to know whether any one of the panelists have any experience in evaluating sciatic nerve damage using ultrasound elastosonography.
No, sorry, I passed that. We fortunately don't get sciatic nerve block damage. In my clinical experience of more than 30 years, I haven't seen one, fortunately. Put it this way. Fingers crossed, I will end my career hopefully with that. But you have a valid question. Sonoelastography may be one way to look at it, but there are no validated studies to show that if you see changes in elasticity of a nerve, how does it relate to nerve damage or to changes within the nerve? I think if that's what you want to know. So there are no validated measures or studies. So I think nerve studies, nerve conduction studies will still be the gold standard until then.
I might contribute something for that. First of all, when you're at the popliteal fossa level, the nerve is really quite separated already within each nerve. So you have a lot of loose connective tissue and fat tissue in between the nerve fascicles. So you get more space which might be filled up first. Second, concerning the elasticity, we are all getting older. And there is a certain age, which is 40, where you get a huge change of elasticity, which means a loss of elastic fibers, and then a stiffness of the connective tissue caused by a lot of collagen fibers. And this might be a reason that sometimes the nerves do not move that easily as you have a young person, for example.
A very valid point, George. I think for that matter, even skeletal muscles have sarcopenia, if you may, and they have changes with age-related changes are quite common, and they can affect musculoskeletal sonography. Maybe if I just put it. But in terms of the question that the doctor put in, there are no validated data as far as I know, and I know that I haven't looked hard enough. But certainly, as far as I know, there are no validated data looking at elastography to quantify nerve damage.
Okay, thank you, Professor Kamaka. So there is another question for you just pop up just now. So Dr. Jamie Etcheper would like to know, where does the paraneal space end caudally? And do you go paraneal in diabetic patients with neuropathy but with lower dose of LA?
That's a very good question. Where does the paraneural sheath end? I think wherever the nerve ends, the paraneural sheath ends. It is an integral part of the nerve. And I think that is how we should look at it, because when you look at the sciatic nerve, it's a template of a big nerve. But smaller nerves also have this gliding apparatus. It's a part of the machinery of within the nerve. Now we inject deep to it to try and augment our blocks, sensory block, motor block, etc. But when it comes to patients with pre-existing neuropathy or patients with diabetes, etc., I think today there are no data. But based on what we understand about these patients, I think subparaneural injections may not be so desirable in these patients, because then if you do it, then you have to think very carefully as to the dose you use, what drug you use, because you may be left with a patient where you perform a subparaneural injection, and diabetics and neuropathic patients who have neuropathy are known to have very prolonged blocks. So I hope you understand where I'm coming from. So in that case, you have to be a bit more prudent and more judicious in what you do. I think my choice, if you take a case, say for instance, a diabetic with polyneuropathy who's coming for an amputation, but has multiple comorbidities, and you just don't want to give them a general anesthetic for nephropathy or any other reason, multiple comorbidities, then my choice is give them a spinal if you can. If you are able to overcome this with a spinal, that's good. But when you can't do it in the risk benefit, then maybe a sciatic nerve block with a combined plexus block, either it's lumbar plexus or a femoral nerve block, would be desirable. But you have to bear in mind that these patients will have a very prolonged block. But the saving grace is often that part of the leg is removed. It means they've had an amputation. But imagine a patient who doesn't need an amputation, like a debridement or some much more simpler thing. Then you have to bear in mind that these patients are at the risk of developing very prolonged blocks. And the reason is very simple, is that you are injecting into a relatively avascular area, a large depot of drug, and this washout of this drug is going to be even slower in these patients because of their vasculopathy, and you may get a very prolonged block. So I think that would be the way I would answer your question.
Okay, thank you, Professor Kamaka. Another question for you from Dr. Tony Ng. So
Okay.
is there any difference in the block dynamic for subperineural popliteal block in the pediatric population?
Tony, that's a good question. Again, we don't do many subparaneural or, deliberately subparaneural in these young patients because they're often done under general anesthesia. And my principle is, if you are going to do a sciatic nerve block, you're often doing it for analgesia. In this, say, somebody having a clubfoot repair, where you do a caudal or you do a peripheral nerve block, then I would usually do a circumferential injection like we used to do in the past. Some of it probably goes subparaneural. But how would it be different? I think that you just bring out a very important question, because I think the washout in these young children may be very fast, and they would be much quicker than, say, somebody who is like you or me. We have a progressively increasing duration and slower offset. So, in younger children, when I do it, I would just do it circumferential injection without really relying too much on identifying the sciatic nerve subparaneural area.
Okay, thank you, Professor Kamaka. I think that's all for now.
Okay, so I think we've had a fantastic evening. We are just about 15 minutes over time. Why not? If the discussion is good, we should keep on going. George, once again, thank you very much, my friend. Hopefully, one of these days I'll fly into Witten, and we should be able to visit your anatomy laboratory and do some fascinating work with what you and me have in mind. Christine, again,
You're
thank you
welcome.
for spending your evening, and I hope you learned as much as I did. And you out there, far and wide, from Venezuela to Algeria to Syria to Colombia to Spain to Portugal, everywhere. This is actually victory of our being trapped inside our homes. We can now communicate. Without this, we would never have been able to bring Professor Bozart. We would never have been able to bring Professor Reiner, Professor Feigl, and myself together in one same session so easily. And for you to sit in your home with the feet on top of your chair, listening to us in the comfort of your home, this has truly been a wonderful time. So I hope you take away something very fruitful from this session. But as I mentioned, you have to be prudent and apply this information to your patients, being prudent in your own way, in your own circumstance. So without further ado, I'd like to wish you all well, and hopefully we will see you in 2 weeks' time for more fun with the ISSPS webinar. Thank you very much, and take care and stay safe. Bye, George, and bye to everybody.
Thank you, Mano, and thank you for all.
Sorry, Miguel. I thought you were not here. You were here, so we're going to spend a few more minutes. Thank you, Miguel. You've been a great champion in your own way. Your contribution in the field of microanatomy is truly stupendous. It has left an indelible mark in our field of regional anesthesia. And some folks who are wanting to know what is the textbook of Dr. Reina, I would suggest you Google Professor Reina, Reina, in Google, and you will find out in the picture section his textbook. It's a must-have book for anyone interested in regional anesthesia or microanatomy of the nerve. Thank you, Miguel. You are always been a great helper to or a champion and a great associate for the ISSPS. I am totally indebted to you.
Okay, I am in spirit and here with you all.
Thank you. On and on. Take care. Bye-bye, everybody.
Bye-bye.